Thanks a lot for allowing me to participate in this wonderful event where I've learned a lot from everybody else, and I'm grateful to be able to help out. Wait for my slides to come up. Or if not, I'll just talk without them. Oh, here we go. Great. Thank you very much. Oh, there we go. Thank you. Are you going to be advancing them, or will I? No. Thanks. This is in part to talk about the science that's needed, and I'm going to, we've actually heard some good things in our previous panel about some of the science behind implementation, payment models. I'd like to talk a little bit about some of the implementation challenges. So this may be a little less data-driven and more maybe qualitative in terms of experience. So as we all know from the alternative payment mechanisms have been proposed to create value instead of volume. That relates to cost and quality, but it also relates to accountability and risk shifting, essentially trying to implement a budgetary process in the healthcare system. Delivery system changes can be incentivized, and we've heard about how that is not often sufficient. And there are currently today in many systems of payment both rewards and penalties. Basically almost everything, at least from the Medicare point of view, and in many of the Medicare Advantage plans and commercial insurance across the country, there are varieties of different rewards and penalties that can occur. Now, although incentives are insufficient and there needs to be funding, I think it's important that it did create a significant shift in the way people can look at things. When I was in Blue Cross and Blue Shield of Rhode Island, one of the leading advocates for this type of work in the Blue Cross Blue Shield Association said for the first time, the quality improvement department in a hospital was no longer a cost center. It was really potentially a revenue center. So flipping that thinking is very important. And I think that change in mindset has led to people implementing programs besides just their interest in providing good care to programs like HELP, to geriatric co-care, to the geriatric emergency department, and palliative care when the business case was made for that as well. But it is important that these new systems look at funding changes in healthcare. I used to hear people talk about when we were doing the patient-centered medical home demonstrations in Rhode Island, what's the return on investment? And one of my thoughts on that and answering that is sort of a smart aleck response, even though I was working for Blue Cross, is, well, what's the return on investment of having no primary care left in this state? Because that's really about what was going to happen. What's the return on investment when somebody orders an MRI? These questions don't necessarily get asked, and I think if they're going to be asked, which I do think is reasonable, they need to be asked fairly. One of the major things here that we would be looking for is that creating flexibility in payment mechanisms so that one can look at attaining certain goals now that you're responsible for the budget. Now, there's a lot of challenges to implementation. We know this in almost everything we do, that it takes a long time. When I look back at when we started working on the patient-centered medical home in Rhode Island, I'm kind of shocked as to how many years it's been. But in fact, it does take a long time to get things going. And we want them to be a success for everybody, not just the provider community, but most importantly, of course, the patients and their family. Next slide. What are some things that we might call alternative payment mechanisms? Well, one of the earliest ones was Medicare Advantage. It was really an alternate way of providing for Medicare payments and should give people more flexibility, should give programs more flexibility, and especially now with some of the alternative benefits in the last year or two, that should be happening. And when we've been talking today about Medicare funding, one should remember that in just a few years, 50% of Medicare funding is not going to be in traditional Medicare. It's going to be in Medicare Advantage. Now, Medicare can teach Medicare Advantage and regulate Medicare Advantage, and Medicare Advantage can teach Medicare and teach the communities and the ACOs. So there's lots of back and forth ideas, but it is important to remember that they are somewhat separate, and it is literally going to be 50%. Now, there have been a couple of studies on some basic things which were sort of the first activities related to care coordination. Dr. Berwick and Jonathan Blum had just come into the CMS administration, and they were very aware of the patient-centered medical home. They thought there should be a change in evaluation and management services, the office visits. Payment should be different, and it should be sort of specialty oriented. I was on the CPT editorial panel and very involved with the work of the RBRVS Update Committee, and we explained that those codes are not specialty specific. They have to work for everybody. So the answer was, what could we come up with to be alternatives that would recognize some of the services on a fee-for-service basis? And two of the procedure codes that we came up with were transitional care management and chronic care management. And each of them has a little bit of a history to them, which is interesting and shows you how long it takes to implement things. But each one, they were evaluated, showed improvements in cost and in quality. And these were independent evaluations and peer-reviewed literature. Next slide. That said, I think the fee-for-service system, as much as it's heavily criticized, and I maybe am a little defensive, having been involved in the description of so many services, it is widely available. You don't have to be a large organization where you might be able to take on risk. You could be a small practice and provide some of these services. So it has a lot of flexibility. There is always an opportunity to create new service descriptions, especially response to coverage changes. So for example, it was very clear Medicare had no interest traditionally in covering non-face-to-face time. They said, oh, it's all part of the office visit, you just do follow-up. The fact that you're a geriatrician and do 10 times as much of it as someone else, or you're a primary care doctor and you do 5 times as much as somebody else, is irrelevant. Well, that changed, and we put forth the chronic care management codes and the transitional care management codes. Now, interestingly, the chronic care management codes were rejected by Medicare for quite a long time. ASPE wanted a lower level service, which we didn't understand for a couple of years, and tried to rearrange the coding. First made it even more complex, and then finally learned what Medicare was really looking for. And transitional care management, when it was rolled out, they said you couldn't report the service or bill it until the 30th day. And if the patient died, you couldn't report it at all. So heaven forbid you actually helped people in important care decisions at the end of life. You couldn't report that service. So it didn't get implemented. And the chronic care management codes were not even covered for several years. So if you look at the trajectory of these important services being implemented, these were some major stumbles right at the beginning that have been since rectified. But there's lots of different other services. They probably do perform the backbone of alternative payment mechanisms. In some places I've read, that all the services have to be provided by a licensed person, and they're talking clinical staff. Of course, to report it to Medicare, you have to be a physician or a nurse, advanced practice nurse, or a PA. But the clinical staff does not have to be licensed, and that is, I think, a misconception. It's not in CPT, it's not in Medicare. It doesn't address community-based organizations. That's candidly the case in almost all these systems. Even if you give someone the money to pay for something that might save money, it's a calculus they're making. So I used to work with my nurse care managers at Blue Cross and saying, like, well, could we provide a service that is not normally covered that might save money and in the long run? And that's a real tough judgment call, and I suspect we're not very good at knowing how to make those judgment calls, and this is the type of thing that we need to learn. But there are new services. We've heard about caregiver training. There's codes will appear in CPT 2024. Whether Medicare will accept them or not, I don't know. For occupational therapy and physical therapists, training the person who is going to take care of the patient in the long term to continue on those therapeutic plans. There is caregiver behavior management training that will be done by behavioral health clinicians. And of course, we've seen an explosion in telemedicine being allowed, digital medicine, and these are important services for managing people in their home. This again also doesn't address all the informal caregiving, but at least provides some education for them. And of course, in facilities, we're aware of changes as well. DRGs was mentioned earlier, readmission penalties, and of course, we even could, even though it was mentioned that nobody gets paid more money for being an age-friendly health system, they could give a bonus to every DRG payment for meeting that standard. Next slide. So it has been proposed that there be a disease-specific alternative payment mechanism for patients with dementia. And there's good literature for support for that being cost-effective. And I think a lot of great thought has gone into this. And this is critical because it can make the case for anybody, whether there is ever a disease-specific alternative payment mechanism, it makes the case for an ACO or a Medicare Advantage plan for implementing them. And so that work is very important. Next slide. Now, there are some challenges to having disease-specific APMs. First of all, a lot of them have really been tied up in the PTAC. MedPAC has recommended no more APMs. There's a lot of complexity potentially designed. Now, this is one is well thought out and is reasonably simple, but you still get into all sorts of issues regarding who is the population, who does the money go to, how do you measure the quality? Are you just funding something like in the patient-centered medical home? Mostly was just funded. There wasn't a lot of a quality measurement that had to go into it. And as a geriatrician, I find it somewhat amusing that a person that's fundamentally focused on primary care and whole patient care is now going to carve something out and give it to somebody else. And so geriatricians will be fighting with other primary care physicians as to who's going to provide what service. Hopefully not fighting, but coordinating, of course. And these things are sometimes difficult to scale and replicate, so that even if there was payment for it, it's not necessarily guaranteed that it would be built. But I will say that in our own community, we have now, using the license of Dr. Rubin's program at UCLA, and we are planning on implementing it, and I hope it will be part of our ACO, because I do think that it has great promise. After all, it's literature proven, and if we can implement it the way it was studied, hopefully we'll have success as well. Next slide. I do want to make a case for those programs that already exist. So Medicare Shared Savings Program, if people believe there can be savings, they can implement it. There's already patient experience measures in there that very much reflect people's wishes. It's a risk-adjusted budget. You can use non-licensed staff. Again, it doesn't necessarily have all those investments in community services. Primary care first. My practice is involved in that. We are involved in CPC Plus. Very important for infrastructure support, a permanent telehealth waiver. There is risk adjustment for the whole practice. In CPC Plus, you got extra payment for having patients with dementia. In primary care first, you don't. For people that have a small percentage of their practice having people with dementia, this is not going to change their behavior, so I think that was an unfortunate change. Next page. And don't forget, the best way to avoid a difficult transition that has to be managed is to not have the patient be in the hospital in the first place, so provide good primary care, support programs like Independence at Home and Hospital at Home, which have great promise. Thank you.